Cushing syndrome involves a chronic and excessive cortisol production by the adrenal cortex or from external glucocorticoid use. The causes for Cushing syndrome include an ACTH-secreting tumor of the pituitary, the non-pituitary tumors of the lung, the pancreas, or the gastrointestinal tract, as well as adrenal tumors or carcinomas of the adrenal gland. Exogenous glucocorticoid can as well cause Cushing syndrome. Cushing's disease, on the other hand, is a specific type of hypercortisolism that is caused by an increased ACTH hormone secretion from the pituitary adenoma. This pituitary adenoma is usually of the benign origin. Both Cushing syndrome and Cushing disease involve the glucocorticoid hypersecretion, but the sources of these are different. The diagnosis of Cushing syndrome and Cushing's disease include the dexamethasone suppression test. In this test, normal individuals' cortisol drop below 5 micrograms per deciliter, and in patients with Cushing's disease, cortisol remains elevated. The 24-hour urine-free cortisol level is also measured, where a normal range is between 20 to 90 micrograms per 24 hours. Any levels above 100 micrograms in 24 hours indicate a presence of hypercortisolism. In Cushing syndrome and Cushing's disease, the common findings include a generalized muscle wasting and weakness, presence of a moon-like face, a buffalo hump, truncal or central obesity, supraclavicular fat pads, and other features include weight gain, hirsutism, hyperglycemia, hypernatremia, hypokalemia and hypocalcemia, hypertension, fragile skin that is easy to bruise, and a reddish-purple striae on the abdomen and the upper thighs. In case of Cushing syndrome and Cushing disease, monitoring of vital signs and lab values, particularly blood pressure, glucose levels, and electrolytes, is key. You need to prepare these patients for radiation therapy if the cause is a pituitary adenoma, and administer chemotherapy if it's due to an inoperable adrenal tumors. These patients may need surgery to remove the pituitary tumor if the condition results from increased pituitary secretion of ACTH hormone. Patients may also require adrenalectomies if caused by an adrenal adenoma. A lifelong glucocorticoid replacement might be necessary. Track the patients on dose adjustments during stress, assess for postoperative thrombus risk, and provide an emotional support for body image concerns.